everyone. Thank you for joining us for the IBD Explore webinar. We will start in just a minute, but while you're all waiting, there will be an interactive portion to the webinar. So please scan the QR code that you see on the slide. Alternatively, you can go to slido.com and enter the code that you see on the screen so you can participate in the interactive portion, which will be a bit of a poll during the webinar. Okay, great. I see it's a minute past the hour, so out of respect to the people who joined on time, we'll get started. Thank you all for joining us today for this PathAI webinar focused on a really cool algorithm that we'd like to tell you about called IBD Explore, which is about exploring biomarkers in inflammatory bowel disease from H&E slides. As I mentioned, there will be an interactive portion, so please scan that QR code. We could have the next slide. There are just a few legal disclaimers. Don't worry, I'm not going to read this entire slide. Feel free to screenshot it if you would like to read it. I'll just read the first paragraph. This webinar is intended solely to provide information to a general audience. The information presented is for general purposes only and should not be construed as professional or medical advice from PathAI or its affiliates, associates, employees, or representatives. So we'll get started with the webinar itself. I'll start with introductions. Welcome to everyone. My name is Eric Walk. I'm a pathologist and the Chief Medical Officer here at PathAI, and it's really my pleasure to be joined today by two esteemed colleagues, Drs. Feda Najawi and Christina Jason, and I think I'll let Feda and Christina introduce themselves. So Feda, maybe to you first.
Yeah, absolutely. Thank you, Eric. So my name is Feda Najawi. I'm a GI and liver pathologist and director of pathology at PathAI. I have been the lead pathologist on the development of our IBD AI model. So very excited to be here with you today and share some of our work. And I'll pass it on to Christina.
Thanks, Feda. Hi, everyone. I'm Christina Jason. I'm Associate Director of AI Products here at PathAI, leading our inflammation and immunology product portfolio. So I've worked very closely with Feda over the past years developing our models in inflammatory bowel disease. And again, very excited to be with you all here today to walk you through them and some really exciting case studies.
Great. So with that, we'll go to the agenda. And again, you can see the QR code for the interactive portion. So we have three topics to share with you today. I'll provide a very brief overview of PathAI, just in case you're not familiar with our company overall. Then the majority of the content will be shared by Feda and Christina, and they together will tell you about what IBD Explore is and how it can be used to explore biomarkers in inflammatory bowel disease. That will include a live demo of IBD Explore on the AI site platform, as well as some very interesting case studies where Feda will tell you about how to explore specific biomarkers using what we call human interpretable features. And part of that will be a recap of a really interesting poster that we presented at the 2024 European Crohn's and Colitis Organization Conference. So with that, I'll take the next slide and maybe go one more. Just an overview of PathAI for those of you who are maybe new to our company. So we are a pathologist-led AI and digital pathology company. We are very proud that we were founded and are led by pathologist Dr. Andy Beck, who did his training at Stanford and was later at Harvard. And it was really in his lab at Harvard where Andy had the vision to develop and grow a company focused on digital and AI pathology, and really with a laser focus on problems to be solved in both clinical pathology as well as translational research pathology. So you can see on the left, the mission for the company from the very beginning has been to improve patient outcomes with AI-powered pathology, and we've gone about and pursued that mission very intentionally through several things. One, unlocking the full potential of biomarkers from pathology, especially from morphology, like in the H&E slide. And I think today's webinar will be a good example of that in the setting of IBD. Second, we feel very strongly that we want to bring what we call precision pathology to the masses, both on the clinical side and the research side. And we hope that by doing both of these things, this will lead to improved diagnostic accuracy and optimal time to treatment. In terms of our company history, you can see the timeline above. After founding, we really started our focus on translational research, and of course that continues today, where we build AI and machine learning tools to address issues in translational research and also discover novel biomarkers, which you'll hear about today. And as a relevant data point that you can see below is that we're very science-driven. To date, we've authored over 75 peer-reviewed posters, presentations, and manuscripts on leading journals and leading conferences using our products. Next in the progression, we moved into clinical trials where you may know, we have a CAP/CLIA dedicated biopharma services lab in Memphis, Tennessee, where we are capable of running phase 2 and phase 3 trials across a number of disease areas to deploy AI machine learning tools directly into those trials. And we also have a dedicated platform, this GCP, GCLP certified, to do this. And the vision here is to ultimately create IBD devices and perhaps companion diagnostics that are AI-based. And you may have seen back in February, we announced a very exciting collaboration with Roche Tissue Diagnostics to do just that, to work with Roche to develop AI-based companion diagnostics. Maybe a quick word on the lab, because you may have seen last week a very exciting announcement from us where Quest acquired our laboratory in Memphis, Tennessee. And I just wanted to clarify, because there's been some confusion. Number one, Quest only acquired our wet laboratory in Memphis, Tennessee, not the entire company. And the second thing I'll mention is that the CAP/CLIA Biopharma lab was not part of that transaction. So that remains under PathAI control. Finally, on this timeline, you can see we've now built a part of the business called digital diagnostics, and this is about really bringing precision pathology to the masses. And so we've created an industry-leading image management system called AI Sight that is a IMS that has fully integrated AI, which I think is really important in this space. That's not the point of this webinar. We host other webinars. If you're interested in AI Sight, I recommend that you tune into one of those or visit our website or speak to the digital diagnostics team. So with that, I think I'll go to the next slide and really get into the meat of today's webinar, which will be focused on translational medicine and clinical trials for IBD. And I wanted to share our overall philosophy for how we could embed machine learning and AI tools into drug development. And that philosophy is, as you see on the slide, that there are opportunities to use these technologies across the entire spectrum of development, from discovery to late clinical development. So in the discovery realm, we have multiple proof sources, posters, and other sources of data to show that it is possible to discover novel digital biomarkers using AI from things like H&E slides, but also IHC slides and even multiplex slides. And this is definitely an area that's very exciting, because we've shown that you can discover biomarkers that are just not possible to discover via the human eye. Then moving into early clinical development, here's at this phase, partners are often interested to refine a scoring system that's maybe digital or AI-based to determine responders versus non-responders, perhaps explore mechanism of action, pharmacodynamic effects, pre versus post-drug delivery. And we've also demonstrated that the technology can be used for these purposes. And then in late clinical development, here, obviously, we're very focused on using the technology to interrogate whether patient outcomes and drug response can be predicted using this technology. And this is what ultimately we think will lead to AI-based companion diagnostics. So really, a lot of opportunity to deploy AI and machine learning across the spectrum of drug development. And at this point, I'll turn it over to Christina, who's going to tell us more about how this philosophy can be applied specifically to inflammatory bowel disease. So Christina, over to you.
Thanks so much, Eric, for that great introduction to our company and really our philosophy and how we approach developing machine learning models in this space. And just to kind of start it off, as Eric said, what are those challenges in inflammatory bowel disease in histologic assessment from translational research through clinical trials? So IBD, as many of you probably already know, is a chronic disease with currently no lasting treatment options. Most strikingly, I think, is that a third of patients stop therapy due to lack of efficacy across inflammatory bowel disease, Crohn's or ulcerative colitis, and key biomarkers are still not identified. So for a chronic disease where people are relapsing, big challenge here is having therapies that are durable. However, we believe that histology actually provides us more opportunities in this space.
And I agree, Christina. Biopsies are routinely sampled throughout the IBD patient journey, but perhaps have not been utilized to their full potential. We know patients with endoscopic mucosal healing are more likely to relapse if they have residual histological activity than, if we compare this to patients who have no histological activity or histologic normalization. So just think that truly we might have insights that are locked in the tissue. Now, at PathAI, we are leveraging AI-powered pathology to get at these challenges, specifically in IBD, and enable precision medicine, or let's say precision pathology in the space. Christina, can you walk us through how we are making this possible?
Yeah, definitely. So really in two ways here. So with AI and pathology, we can, on one hand, enhance what we can see. So augment and enhance what manual pathologists like Feta can do more consistently, at scale, and more quantitatively. It does this can reduce the impact of intra and inter-reader variability, right? That reproducibility, one of these big challenges in the space. It can also standardize the assessment of histologic scores and endpoints, especially in IBD, where there are multiple scoring systems for both UC and Crohn's. It can also improve the sensitivity of patient selection strategies. The second thing that AI can do, which is more exciting for us and what we really want to focus on today, is it can reveal what we cannot see. So really, it's the ability to measure and identify signatures or biomarkers that are invisible or indiscernible to the human eye. So quick example that we're showing here is a graph neural network, which is a type of AI statistical model that captures and quantifies spatial relationships. Here we're looking at these many cell types of ulcerative colitis in this case, and being able to get at those location-based cellular relationships, which we know are becoming more clinically relevant in understanding biomarkers and drug response in this space, but are nearly impossible for humans to evaluate and count across an entire biopsy, across an entire whole site image.
Awesome. This is beautifully put, Christina. Let's talk about our own IBD AI-powered product.
Definitely. So at PathAI, we have really recognized that inflammatory bowel disease is a space that could benefit from AI-powered pathology. So we've got two products here to bring those insights to inflammatory bowel disease, bring those AI-powered insights to IBD. So we have AIM-HiUC, which is AI measurement of histologic index for ulcerative colitis. This is our automated Gibbos-Robarts-Nancy scoring tool that we're actually further enhancing with the Foundation for National Institutes of Health Mucosal Healing in Ulcerative Colitis Consortium. And the goal here really is to improve the accuracy of endpoint measurement and assessment of therapeutic efficacy for ulcerative colitis. But the meat of our conversation today is IBD Explore. So this is our second product. It's our research panel tool to bring comprehensive quantitative insights to power IBD research and drug development. Today, we'll be focusing on ulcerative colitis in our case studies, though we know there is just a greater need and just as many powerful insights that we can glean in Crohn's disease. So before we dive into it, this is the interactive part. We'd love to hear from you all on the call. In a couple of words, what do you see as the biggest challenges in specifically ulcerative colitis drug development? So as Eric said at the beginning, you can scan this QR code and participate, or you can join in by going to slido.com and entering this number 1379155. And we'll give everyone maybe 30 seconds, and then we'll take a look at what everyone's thinking. Okay, a couple more seconds. All right, let's see what everyone's thinking.
Okay.
One participant, I just want to give this last person to finish typing here. Okay.
Okay, thank you all for your participation. So I see a few things: biomarker, timelines, host resources, understanding non-response, response, stratification, and efficacy. And this is all awesome, kind of bringing all these up here, and they do resonate with the challenges that we do see in the space. So thank you all for your input. And Christina, that was a nice overview of the two IBD products. I think from a pathologist perspective, there are specific histologic changes in the tissue and cellular composition that are evaluated. Can you share how we designed IBD Explore to translate what the pathologists see into actual tangible data and insights?
Definitely. And we'll start there. And then I think a lot of the case studies that we have today are going to directly address some of these challenges in development. So
yeah,
really excited to hear that. Again, as Feta said, we're on the same page, everyone. So let's walk through first how IBD Explore works and the outputs. So IBD Explore provides quantitative, comprehensive insights into the inflammatory microenvironment at multiple levels. So we start off with our H&E whole slide image. This is a zoomed in shot of one, but this is deployed or assessed across an entire whole slide image, be there one biopsy on that slide or multiple biopsies on that slide. So we first have our artifact model, which is this electric yellow here, and this masks out regions of artifact. Crush, blur, tissue folds, areas that a pathologist wouldn't use. Then we have our tissue model that predicts regions of tissue that are inherent to the colon. So that would be like your muscular mucosa, your crypt lumen, your lamina propria, but also pathophysiological regions such as granulation tissue here in black and cryptid abscess in red. We're able to segment out each of these crypts as well, and then determine whether it is inflamed or normal based on infiltrated epithelium, or obviously if it's a crypt with abscess. Then zooming into our cell model, for every nuclei that is identified, we are able to classify that cell into one of these 8 cell types, such as plasma cell or neutrophils. And you can also see at this scale, I think, a little bit better that another tissue region that we're able to segment out or predict is goblet cell mucin. So from these many models, we extract quantitative features we call human interpretable features. So this is across a whole slide image, taking in information from all of these cell models at these different levels, right? So we can get at insights such as the density of neutrophils specifically in the lamina propria, or the proportion of crypt abscess to total usable tissue area. These features can then be leveraged to investigate therapeutic mechanism of action or to predict or prognosticate outcomes, such as which patients are likely to respond or not respond, or which patient is likely to relapse or experience flare, hospitalization, etc. So with this kind of context of the basis of IBD Explore, I actually think, and I have found that seeing these models in action is really what will help us, appreciate how they work. So Feta, I was hoping that you could walk us through what IBD Explore looks like on our AI site platform. How do you as a pathologist interact with IBD Explore?
Yeah, absolutely. And I'll share my screen.
Yeah.
Yeah, perfect.
Are you able to take over share?
Not yet. I think it needs to stop sharing. Okay, perfect. Let me. Okay. So I hope you see my screen.
Yep.
Okay, perfect. So I'm starting here at the kind of more the project page. So this is what you would have access to when you want to look at the data set that you shared with us so that we deployed IBD Explore models on. And so in your overview page, you'll see at what is the status of the project, at what stage of kind of deployment or feature extraction the model, the kind of the project is. But you also have access to the report. So here you have access to the actual deployments and the IBD Explore HIF report. So these are the human interpretable features that we extract, and you'll have access to all the features that we provide from IBD Explore. You have access to your slides. So if you want to look at, which slides you provided and kind of get an overview of that, you have access to those on the same page. And then most importantly, and what we're interested here, and would be the overlays. So under IBD Explore, as Christina has just described, we have multiple models. And you'll have access to the overlays or the model predictions under that in that area in your project phase. So you'll have access to the tissue model, the goblet mucin model, the cell model, and then the artifact model. And you can access any of these. You'll have access to all your slides, as well as the deployed model on all these kind of cases that you included in that project. And you can click on each of these cases and take a look at the actual model prediction on top of these H&E whole slide images. And so here is an example. You might want to adjust the orientation of the slide to your liking. You have that functionality on our AI side. I do have the tissue model here turned on. I can add other additional models. I can look and compare at what the model prediction is like by looking at a side-by-side view, adding a panel here and looking at the H&E at the same time. I have the options of looking at other slides from the same patients, or kind of focusing on and pointing on a specific tissue area. So let's say I want to look at what is in the lamina propria. I can toggle on and off each of these substances or areas. And I also can add, additional models on top. So let's say I want to look at how the cell model is doing in these areas. I can put that on. Or if I don't want the models on top of each other, I also have the ability to add another panel and select that other model in that area. And you can add up to 4 panels here. So kind of however, or what is your preference in terms of looking at the slides and the model output, you can decide as you interact with the platform. You also have, details on the side here, including the metadata for a specific slide that you can access. You can add comments as well to the case. And this is another, functionality that will be helpful if you want to communicate with other team members. Essentially, all of the kind of shortcuts to the different things that I was doing are also here under keyboard shortcuts that you can use. But what I want to show at this stage is really more a case that has, some of these histopathological changes that we look for in IBD. So I'll stop this share and I'll share another example. Okay. Can you see a case here with the perfect? Okay. So here we have a different case where you can actually see changes of more severe disease. So this is a case of chronic active colitis, severe chronic active colitis. And even from before you zoom in and look at the tissue, you can see there's a lot of black, which our model indicates that there is granulation tissue or an area of ulceration. So even before closing to look at the tissue, you can tell there is a significant amount of ulceration in this tissue biopsy. And as I mentioned previously, you can have a side-by-side view. This is my preference usually to look at, how the model is performing. You can look at specific tissue regions. So let's say I'm interested to see how is the model predicting areas of infiltrated epithelium, which should indicate epithelium that has neutrophil infiltrating into it. And so this is an example here in yellow. The model is making a prediction on a crypt epithelium that has many neutrophil infiltrating into the crypt epithelium, as opposed to that crypt next to it, where there's no neutrophil at all within the epithelium, and the model is correctly calling that normal or uninflamed epithelium. You can also look at other things within here. So let's say I am interested in looking at the lamina propria. So there's so many different ways that you can do that. You can kind of change the intensity of the color of the tissue overlay. Or you can, as I mentioned in the other example, toggle on and off certain areas within the tissue. But I want to look at the cell predictions in here. Let's take a look at, how the model is doing in terms of prediction in lamina propria. So you see the inflammatory cells, and let's say I'm interested in, the eosinophils. I don't want to look at everything else for now. You can turn off the predictions of all the other cells and just look at the eosinophil predictions. And you can see how the model is nicely picking up all these eosinophils within the lamina propria. So really very sensitive and specific in terms of predictions. But let's say I am more interested in, let's say, areas of granulation tissue. How is the model doing at predicting eosinophils in areas of granulation tissue, which is here in black? Again, here what I can do is change the intensity of the color. I can also turn granulation tissue off, and I can see the model is picking up all these eosinophils within granulation tissue. So really so many ways to look at it, but essentially you can look at the different features within the tissue and see how the model is predicting these features. And if it does look like, in terms of sensitivity and specificity, the model is doing a good job, which it is doing in this case here. Another point that I wanted to highlight, and here I have another case in which I have the goblet mucin model turned on, and you can see the model is segmenting areas of goblet mucin. What is striking about this case, though, is even when you look at it from a low power, you can see like you have this piece here and this piece here that look somewhat normal. So not much inflammation compared to other pieces on the whole slide image. And that sometimes happens if in the context of your project or trial, you're sampling both normal biopsies as well as biopsies from areas with kind of active disease or more obvious disease. And if you want to specifically, let's say, look at our hips or our features in the disease biopsies or the cases or the biopsies with active or chronic disease, then you do also have the functionality to add an ROI. And that will be an ROI or an area of interest inclusion. Let's say for this case here, I really want to include all these tissue pieces and this. Whoops. I think it got stuck. Are you still seeing my screen?
Yep, still seeing it.
Okay, so it's unresponsive. I'll stop. I'll do that for this case here. Essentially, you can really select the region of interest that you want, whether it's because these pieces of tissue are inflamed and you don't want to include the normal biopsies, or because you want to compare it to, let's say, spatial transcriptomic. So you can select the area or the piece of tissue that you want to compare to, any other multimodal data that you have on hand. And
But actually, there's two questions before you stop sharing from attendees. One is, could you point to the other tissue in the slide? And I think that'll also get to the other question about lymphoid aggregates.
Yeah, so other tissue here is this area. And so for other tissue, this category includes areas of lymphoid aggregates within the tissue, as well as areas of submucosa. So if you look at the predictions that we have normal epithelium and infiltrated epithelium. So that's epithelium that has neutrophil going into it. We have the crypt with abscess, crypt lumen, muscularis mucosa, and lamina propria, and then areas of more severe disease like granulation tissue erosion alteration. But we have other tissue category, and that includes, lymphoid aggregates in the mucosal biopsies, as well as areas of submucosa.
Perfect. Thanks, Feta. And actually, I think as we transition back to the slideshow, we'll be able to get at the second part of this question that we received, which is there a quantification tool? So both kind of in that region of interest approach that Feta shared, where you can, and if you want to stop sharing, Daniel, I'll take back over, you're able to kind of segment out or include kind of regions specifically that you want to, sorry to use the word specifically, but very specifically quantify features within. But then in general, the way that those human interpretable features work that I mentioned earlier is that these are taken across the whole slide image. So you get one quantitative measurement per feature per whole slide image. So these features, I'll just highlight a few, include features such as areas, like the total area. So your total area of granulation tissue, or your area proportion of infiltrated epithelium over all epithelium. They also include things like count. So count proportions. So the proportion of neutrophils over all cells in the lamina propria, or even density. So if you just want to get at kind of the density of cells. It also includes features such as cell ratio. So ratio of neutrophils within lymphocytes within 20 or 40 microns of each other. We also have object level features for crypts. As I mentioned earlier, we have that model. This includes things like the mean area of inflamed crypts or the count of cells specifically within normal or specifically within inflamed or all crypts. So as I mentioned, you get a quantitative value for each feature for each whole slide image. If you are familiar with RNA-seq, you can think of it like each feature as a gene and each feature quantitative value as the quantity of that gene present in your sample. In this case, your sample is the whole slide image. So this is all output in an Excel table where each row is a sample or a whole slide image, and each column is one of those features. And was it?
Yeah, absolutely, Christina. So I think kind of going back to what you described here, we have characterization and interrogation of each corner of the tissue, as I showed on the slide. Each pixel on the slide has a prediction, whether it's a tissue segmentation or an actual cell prediction. And such quantitative features, I think, are powerful data points. And I mean, it's a collective for us that we do foresee this as a tool that will give us the ability to generate standardized characterization across multiple patients and multiple data sets. And hopefully we can reliably and efficiently apply our models across thousands of slides and eventually have, digital atlas of each patient's mucosal microenvironment will be the hope long term.
Exactly.
Now, we want, awesome. So for now, this is another poll here. And what we want to do is to put the pen again in your hands. And this is another poll, as I mentioned, which you can access using the same QR code. Our question for you all is, considering the challenging kind of circumstances and challenges that we see in understanding and treating IBD, what features would you most be interested in leveraging to address your hypothesis? And we'll give you another 30 seconds to give us some answers, and we'll catch up from there.
Right. Okay, let's see. Okay, so some of the challenges we've got here is, and some features, okay, unbiased analyses would be most interesting. Yeah, so basically being able to take all the features, and there's over 900 of them, and just seeing kind of what comes up as correlating with an outcome or a response or non-response of interest. Expert level scoring. So I'm going to assume that kind of means at like a slide level score, for example, maybe of Gibbos or Robarts, but then we could also think of each of the quantitative features that comes out, that quantitative value. Perhaps you're looking at, you know, the neutrophil value or the total count of neutrophils. Differentiating the features of UC from Crohn's disease, definitely. So like what human interval features are very unique for UC versus Crohn's? Are there certain ones that are predictive of, or we can leverage to distinguish between the two diseases? Neutrophil quantification, definitely. Data beyond just scoring. And let's see if I can scroll down here. It's cut off a little bit at the bottom for me.
I think some of these we'll also cover in our case studies. So this is awesome to see that we're aligned in terms of, you know, what use cases we have, especially when it comes to quantification and data beyond scoring.
Yes, definitely. And actually, speaking of features, and like, you know, I think this unbiased analysis one gets at it. There's a lot of features. I said over 900. So, but how would you kind of wade through this to take a hypothesis-driven approach? There's the unbiased approach, but then there's also the hypothesis-driven one. Kind of how would you do that?
Yeah, absolutely. I mean, I agree. We have a comprehensive list of features here, and these capture changes in both the cell and tissue, and really a huge amount of data from each slide and each patient. One can approach this by looking, you know, for features that correlate the strongest with a specific endpoint in mind. If we're looking for a signal and we do not have a specific hypothesis on which features or group of features to target. The other approach, and if you go to the next slide, awesome. The other approach would be to group features that describe a specific histopathologic change or cell type. And there are so many different ways to do that. It can be a general grouping, for example, just looking at features quantifying, let's say, mucosal inflammation, regardless of cell type, or be slightly more specific and look at hits of chronic inflammation. So that would be including lymphocytes and plasma cells, or, you know, be a bit more granular and specifically look at hits of plasma cells. And this can be driven by, you know, the hypothesis that you want to examine as an investigator or a pathologist.
Right. It sounds like this is really amenable to kind of whatever the hypothesis is, there's different routes you can take. Would love if you could give me an example of how you could use this approach, this kind of categorization or grouping approach, and therefore our features for investigating mechanisms of action.
Yeah, absolutely. So yeah, if we stay here, that would be awesome. For mechanism of action, really it is multifaceted and complex. Of course, if we think about inflammatory cells in the mucosal microenvironment, these do not function in silos, but are rather affected by multiple signaling pathways. However, if we want to look at an example like vedolizumab, for example, which is a monoclonal antibody that was used to specifically bind the alpha-4 beta-7 integrin, which itself is a protein on the surface of lymphocytes, and plus it interferes with lymphocyte trafficking in the GI tract. Essentially what it does, it blocks T cell recruitment. From such understanding, or maybe rather a simplified one, we can target looking at lymphocytes in the mucosal microenvironment. And that will be one example there.
Got it. And so this is a category, HIFs of lymphocytes in the mucosal environment. What are the specific features within those categories for quantifying lymphocytes?
Yeah, absolutely. So if you go to the next slide, we can see here a list of some of these features. These features include lymphocyte quantification, and it goes back to what you described, what IBD Explore quantify, things like proportional counts or densities of lymphocytes. whether it's in the entire mucosa as a whole, as what is shown here on the overlay on the right, or specifically HIFs of lymphocytes infiltrating the epithelium, for example. Maybe this is where we want to target looking at lymphocytes, whether that's within the crypt or maybe in the surface epithelium. You can kind of look at which features you're more interested in, but the category would include all these features in different compartments. Maybe it's the lamina propria that you're interested in, or areas of more severe disease like granulation tissue. Essentially, the HIFs are characterizing lymphocyte infiltration in different tissue regions, and one can examine the change in such feature after commencing the treatment and looking at the delta of change between, let's say, baseline and induction at week 12, for example. And these HIFs can also be correlated as a category, as well as the strength of correlation for each of these individual features can be examined to get at where the change is happening within the tissue.
Very neat. I love how we can look at this kind of at an individual feature level, but then also at a combined feature level to see if that actually strengthens it. If you're really capturing all of the differences of lymphocytes across many different regions, but then really getting granular and saying, okay, maybe it's just, maybe the strongest, what's driving that correlation is the density of lymphocytes in the lamina propria. And going back to what you showed us in your demo, is this what we can see on the side here, right? Those lymphocytes in the tissue using IBD Explore?
Yes, absolutely. So all these green dots within the lamina propria, as well as some of the cells within the crypt epithelium, are all lymphocytes. And some of these are lamina propria lymphocytes, and some of them are intraepithelial lymphocytes within the crypt. And this is what is the IBD Explore model prediction shown here.
And it looks like in the chat, we don't have a question, but more of a comment that I'll read. They say, and thank you for sharing this, there was a recent publication demonstrating that vedolizumab impacts the lymphoid aggregates, but actually not the T cell infiltrate.
Yeah, absolutely. And I mean, if you look at the H&E per se, what we're predicting here is the combination of, lymphocyte as a whole. There is no way for a pathologist to differentiate a T from a B lymphocyte apart from, a well-formed plasma cell where you can tell this is a B lymphocyte. So based on this, the quantification is really of lymphocyte as a whole in the tissue, and the density of lymphocytes, especially in other tissue, which segments areas of, areas of lymphoid aggregates in the tissue, would be a good kind of correlate to what you described in the literature.
Thanks, Eric, and thanks, Sarah. I love that you can both kind of visually see exactly what the model is capturing on each slide. So like just the lymphocytes across the whole slide image, but also that you get these quantitative HIFs to power your analysis, lymphocytes in each of these different tissue regions. So being able to parse that out when across a whole slide image, I think you as a pathologist would be able to visually see it, but definitely not quantitatively get at that. I'd like to go back actually to one of the big challenges that I brought up at the beginning, where a third of patients are losing response within 12 to 18 months of starting a therapy. So how could we leverage HIFs to identify what histology characteristics would indicate the likelihood of response to a drug, or just as importantly, what came up as challenges in the space, non-response to a drug? So who wouldn't respond?
Yes, absolutely. I mean, this is the million-dollar question. So we want to answer, and we now have tools to hopefully answer that just by using the H&E slides, which are readily available for all the trials on hand at the moment. It would help us, I think, push really the boundaries of precision pathology in the space. Let's go back to the vedolizumab as an example here. And I mean, this example is not kind of the only biomarker that has been looked at, but it's something that I want to bring up to showcase how we can use IBD Explore for such purposes. So one of the biomarkers that came up is mucosal eosinophil, and it has been recently proposed as a biomarker predictive of response to vedolizumab. A potential marker like this or biomarker like this comes with its challenges. And as Eric described, and as you described, Christina, previously, there is inter-observer variability between pathologists. It's really hard to determine and accurately measure this across the entire tissue that is being sampled. And so really traditional manual pathology assessment can have this variability or inconsistency, and that's kind of inherent because it's qualitative or at most semi-quantitative. Now, if you go to the next slide. Yeah, so using IBD Explore, what we can do is we can precisely quantify the proportional counts and densities of eosinophils within the mucosal myopathies. And you can see the predictions of eosinophils in the lamina propria here on the example on the right. And we do not stop there. We can spatially measure where the eosinophils are present across different tissue compartments, such as the epithelium, the lamina propria, the granulation tissue, or even the entire mucosa. And so this is kind of really powerful in terms of it being unbiased and kind of more it kind of decrease that variability in terms of the assessment overall.
Yeah, and I can see how that variability and semi-quantitativeness could really be barriers when trying to identify and develop an accurate and reproducible biomarker. But now you've shown us that we can really leverage elements of IBD Explore, that reproducibility aspect, that automated approach, and also the quantitative aspect of it for eosinophils in this case, which is, as you mentioned, a proposed biomarker of response. Do we already see that in patients with the same disease severity that they might have different underlying histological characteristics with IBD Explore?
Yeah, so if we look at the two cases here, absolutely. We looked at cases with similar disease severity. So we have two cases here, case 1 and case 2, and both are cases with severe chronic active colitis or a Gibbo score of 5.4. As we see in the examples, these exhibit really variable eosinophil infiltration, although they do have the same disease severity. And so really this variation could be critical for predicting which patients at baseline are more likely to respond to treatment, but it has been either overlooked or only assessed kind of qualitatively or semi-quantitatively with the existing scoring system that we know. And this is just a wonderful example of where IBD Explorer can have a huge impact as we work as selective to improve IBD patient outcomes. And as you see here in the example, you can see what the output of IBD Explore in the two cases in the table at the bottom. You can see that the actual density proportional count of eosinophil, whether in the lamina propria or in the granulation tissue, is really show distinct infiltration between the two cases.
Definitely. And I can literally see here how we can quantitatively capture known biomarkers, both kind of visually guiding you, but then also in the features that are output, the 700 to 200 difference between two patients with the same disease severity, and how this could have a really strong impact in patient stratification or just understanding these underlying differences, potentially that could guide response to therapy. And actually speaking about that, this is features that have been known to potentially predict response to therapy. But what about HIFs that could be predictive of response or non-response that are novel, that aren't already in the literature, like this eosinophil example?
Yeah, absolutely. I mean, one thing that I want to highlight here, or a feature that I would love to highlight, are those of goblet cell mucin quantification. Whether it's within the entire epithelium or specifically within, let's say, inflamed epithelium, crypt epithelium, or surface epithelium. This is a feature that pathologists previously tried to qualitatively describe. So if you go to the next slide, we as pathologists describe that as mucin depletion. And it can be really easy to see if we have two extreme cases. So you have case 1 here, which has severe disease, and case 2, which has somewhat normal, really, with no activity. And you can see the kind of mucin depletion really just by looking at the two cases, very distinct. But quantifying subtle changes in mucin content is something beyond what the human eye can achieve. And so one thing that I want to highlight is, based on our experience, we found out that mucin quantification is actually a very sensitive tool in terms of assessing disease severity, which we shared in our recent presentation at the European Crohn's and Colitis Organization meeting, or the ECHO meeting in February, which I will share with you next.
And I know we've got 10 minutes here, so we might not be able to get through all of our case studies, but definitely want to give us time to kind of focus on what we found here at ECHO.
Yeah, absolutely, Christina. So we wanted to look at hits related to epithelial injury and repair and hone in on what changes are happening specifically in that layer. So instead of using all these features individually, we aimed at categorizing the hits based on what they describe biologically. And if you go to the next slide, as you can see here in the table on the left, these feature categories, each composed of a subset of HIF describing epithelial cells and related tissue changes. And we are showing a single example of each category in the middle column, and then the Spearman correlation indicating positive or negative correlation and the strength of that correlation on the right side of the table. We aim to be granular in terms of cell categorization. So we really looked at infurocytes, goblet cell. We looked at spatially where they are. Are they in the entire epithelium? Are they specifically in the crypt epithelium? And we also assess other features related to epithelial injury, like infiltration with neutrophil or loss of epithelial integrity, which is dictated by the presence of erosion, ulceration, or granulation tissue. We assess as well as that, the proximity and localization of inflammatory cells kind of at the epithelial lamina propria junction. So really focusing on that epithelial layer.
And then we were able to kind of correlate that, as you said, Spearman to disease severity here at a single feature level, which is shown in the table, but then also across the entire kind of feature category, right?
Yes, absolutely. And so you can see that I think one thing that was interesting is that using quantification came up as one of the strongest correlation with increasing disease severity. And if you go to the next slide, this is really just highlighting that goblet cell mucin loss in crypt really associated with non-remission, whether you look at it in the entire all crypts, inflamed crypts specifically, or those crypts that are not inflamed or normal.
I mean, this to me is just incredibly powerful, how you can take a single feature here, area of goblet cell mucin in all crypts, inflamed or normal crypts, and really see that distinction between remission status just based on that feature. And what resonates most with me is that these features, like goblet cells and goblet cell mucin that characterize epithelial barrier, injury, and repair, go beyond the existing scoring systems that are typically used in clinical trials, like the Nancy, Kipos, and Robarts.
Yeah, absolutely.
And I think because we have a little bit of time, and I think this would be relevant, would love to just touch on histologic endpoints and kind of features that would allow us to capture those. Feta, could you just dive into that, and then we might wrap up?
Yeah, absolutely. I mean, the current histological endpoints in IBD clinical trial are focused around acute inflammation, or specifically neutrophil. Some of the existing endpoints include histological improvement or histological remission, with different definition really across the literature. While achieving normalization of histology or deep remission could be a long-term patient goal, I think in the context of IBD clinical trial, HIF quantifying neutrophil would be the low-hanging fruit here. And using IBD Explore, HIFs such as those, if you go to the next slide, listed here, either by defining more consistent cutoff for improvement, which would be great, or by simply looking at the total number of neutrophil in the epithelium or the surface area of infiltrated epithelium in the tissue, as you see in the two examples on the right. You can also add, additional specific conditions to achieve remission. Let's say you want to say there should be absence of erosion, ulceration, or granulation tissue in the tissue. But also, if we are interested in deep remission, kind of long term, I think defining normal counts and densities of different cells in the mucosal microenvironment in different segments of the colon is essential. Moving beyond the subjective of mild, moderate, and severe distinction, I think that would be the first step, I believe.
Yeah, and I think that we have, aim high UC, and that provides our automated Gabos, Robarts, and Nancy scoring. These same elements that are also looked at for histologic endpoint can be interrogated at a HIF level. So like if you wanted to just capture neutrophil changes. I'm going to kind of skip through our last example, so we do have some time for question and answers, but wanted to really quickly touch on kind of that deliverable experience. Again, a lot of features. How can you, as a user, make sure you're interrogating them appropriately or in an empowered way? So we have developed these platform tools to help seamlessly filter features for your needs, for your hypothesis testing. So this allows you to kind of filter out feature types like area proportion, or for certain cell types like neutrophils. Let's say, for example, I wanted to look at just inflamed crypts. I could start typing inflamed in the search bar, and what would pop up is really all of those features of inflamed crypt here. But at the end of the day, our goal here is that IBD Explore, both kind of in the way that Feta has walked through it, showing you a demo on the platform, kind of taking you through how the HIFs are extracted, kind of the basis for IBD Explore, how those features are extracted, and then how you can leverage those features in a very hypothesis-driven way, categorization or HIF category approaches. We're really hoping that this will enhance each of your IBD insights from translational research to clinical development. So IBD Explore can be leveraged in a prospective academic study or retrospectively on previous clinical trial data to identify histologic biomarkers. And then those findings can be taken through to clinical development, or IBD Explore can actually be run as an exploratory endpoint in a clinical trial on that GCP/GCLP compliant AI site platform that Eric mentioned earlier. And that can be leveraged to then corroborate mechanism of action or fuel insights for future trials. In each of these settings, IBD Explore can be overlaid with additional insights from other modalities, really empowering those insights if you wanted to kind of combine with spatial transcriptomics, as Feta showed, drawing that kind of region of interest, or to build multimodal models, or even connect findings from less common modalities or trickier modalities, let's say like RNA-seq, back to histology, which we know is a big part of that patient journey.
Yeah, I absolutely agree, Christina. And at the end of the day, I think IBD Explore is a powerful tool that can be easily applied to readily available H&E slides, and that we hope can help make a difference in research and clinical development and ultimately patient life. Definitely.
So with the few minutes kind of we have left, did want to highlight that we will be available and a few of us will be at DDW. And so if you are there, definitely look for us or reach out to find some time to meet. We really appreciate you all joining us today for this webinar and hope you enjoyed learning about IBD Explore as much as we enjoyed sharing it with you all. So with the few minutes we have left, want to open it up for any questions that remain. And again, thanks everyone for joining us.
That's great. Well, thank you, Christina and Feta, for a wonderful interactive discussion and a great overview of IBD Explore. I think it's such a perfect example of how AI and machine learning pathology can be applied to IBD to discover new biomarkers and then deploy them in a translational research or a clinical trial setting. So thank you all for attending. Please drop your questions into the Q&A. Because unfortunately we cannot unmute you to ask questions live. While we're waiting for that, maybe I'll ask a question that may be on the minds of our participants who probably come from the academic world and the former research world, and that is just practically speaking, how if someone out there has a cohort that they're interested to query with IBD Explore, how would that work just from a project management perspective? How do they upload the images? Who does the bioinformatics? And those sorts of practical questions. Maybe one or both of you can give people a sense of how that could work.
Yeah, really good question, Eric. So process is pretty seamless. Obviously, once you kind of get the logistics of a collaboration initiated, we typically transfer images via an S3 bucket. So that means the digital images themselves can be directly transferred to our platform, to our secure platform, where we can then leverage IBD Explore. Other options are, let's say you've got the whole the slides themselves, but you don't have a scanner. Again, we've got our GCP/GCLP CLIA Biopharma Lab with scanners there that you could ship those slides to for scanning. So kind of both routes work. And then once those images are on our platform, so we don't actually need the slides if you already have the whole slide images, we can directly deploy our algorithms. And as Feta shared with you that project page on AI site, you would have access to that where you would be directly able to visualize the overlays on each of those whole slide images, and then also receive and download that HIF Excel. So where each row is a slide or a sample and each column is a feature. And then we at PathAI have a world-class biomedical data science team that can help either guide or actually perform that analysis. again, if you have your own bioinformatics team, we can definitely guide just to kind of, as Feta walked through, how to best leverage the features, because again, there are many.
Yeah, absolutely. And I would just add to that what Christina shared toward the end of the presentation, where you can actually filter the features depending on what your hypothesis is. If you're interested in a specific cell type or a specific feature region, you can filter these and then download an Excel sheet of just the features of interest and kind of do your analysis.
Yeah, well, that's great to know. So people, it's really flexible. So the data provider, they can do the bioinformatics, or we can do the bioinformatics, or have it as a collaboration. So that's perfect. So we're right at time. There are no remaining questions. So again, thank you everyone for joining this webinar. It has been recorded, and we'll send the link out after the meeting. Also, if you want more information on IBD Explore or AIM High UC, you can go to pathai.com, and under the IBD products section, you can find more information there. But thank you, Christina and Feta, for a wonderful discussion today on IBD Explore, and we'll see you all for the next webinar. Thank you.
Thank you.
Thank you all.
And for your participation too.
Bye-bye.
Bye.